Welcome back, and thank you to our speakers on an enlightening and interesting discussion thus far. Next up, we have a panel titled Coordination Messaging from the Hospital to the Community. Joining us are Dr. David Svec, Chief Medical Officer for Stanford Healthcare, ValleyCare, Ms. Kathy Harris, the Director of the Office of Emergency Management for Stanford Healthcare and Stanford Children's Health, and Dr. Oren Caspi, an Assistant Professor and Director for Rambam's Cardiovascular and Innovation Unit, as well as Head of Advanced Heart Failure for the Cardiology Department and the Laboratory for Cardiovascular Precision Medicine at the Technion. So Dr. David Svec.
Pleasure to be with everyone today. It's been an interesting time, and it's been fascinating to see how the community has come together. There's been a couple different features that we've noticed as the community has come together. There's been not only a regional and governmental work and collaboration, but there's also been a fantastic work within the organization to make sure that we have a coordinated response to go to the community. The government and regional coordination has been fantastic in Alameda County, which is about 70 kilometers or 40 miles away from Stanford Palo Alto. There's been the ability to work together on testing, on drug distribution, and a couple of other items. And also within Stanford as an organization, there's been great coordination between all different parts of Stanford and make sure that we can give a good response and a great patient experience. So it's been fascinating to see how, again, each has worked together in order to make sure that the community is safe during this time.
Oren?
So thank you. It's a pleasure and privilege to be here. I think that this is a very interesting session talking about our interaction with the community during this crisis. And I think that the key here during this crisis is that we need to bring healthcare to the community in order to prevent the community from coming to us. This became very, very important during this crisis. So thank you for inviting me to speak here.
And Kathy, I'm looking forward to hearing from you quickly, just to remind our group to add their questions, any questions to the chat function.
Sure, I had a few remarks prepared here. I just wanted to put that from an emergency management perspective. We say that all disasters are local, and so that's not just in regards to the scope of the incident and who's impacted, but also which resources are available to recover and respond. And every component of our health system and community has really been impacted by COVID-19 in some way. There's also a role to play in each of our parts of our community in responding to and recovering. And so when a disaster occurs, federal human and material resources are not necessarily going to immediately arrive at our facility. There's definitely programs, but particularly in widespread and long-lasting things like COVID-19, it's been pretty slow and sparse, as Ali alluded to. There's no such thing as a perfect emergency response plan, but there are some starting points and frameworks at best. And so the most important role of an emergency manager is to build relationships with our internal and external constituents. And so I'm happy to provide some examples, or perhaps we can just go to the questions and take it from there.
So I think one of the things I'd like to hear about, this is Dr. Masters, one of the things I'm interested about is some of the ways that we dealt with community messaging and internal messaging when perhaps not only was this an evolving pandemic with changing information, but also with some of the messaging coming from the federal and state level being perhaps inconsistent. So what are some of the strategies we had to deal with that?
Yes, I can kick us off. I think one of the most challenging things is something that we saw probably most similarly during the times of Ebola as well, when the guidelines and recommendations, it felt like they were changing daily, if not fast enough. And like Ali alluded to, that's one of the biggest challenges with communications is being transparent and keeping your staff aware of those changes, helping them understand why it's changing, because there's a lot of integrity behind that. As soon as people start to get used to one thing, we switch it up, and particularly when it's things regarding infection control and personal protective equipment, we want to make sure that the information that we're providing them is something that they can trust and that they feel safe for themselves and their patients.
Meredith, if you don't mind, so I want to share some of our experience with the interaction with the community and the hospital preparation. So I will share screen and show some of my slides.
Thank you.
Okay. Fantastic. You see my slides now?
Yes.
Okay, fantastic. So I think that in Rambam, and Dr. Halbert talked a little bit about it earlier, we understood that there are four pillars for COVID-19 crisis management. And the first is the hospital infrastructure and the medical equipment needed. But I will talk about three pillars. One is the command and control and communication system needed during this challenge. The second is the preparation and the training of the medical staff. And the third one is harnessing data science in order to help us cope with this challenge. And I will focus on that and help us communicate with the community and our region in order to prevent COVID-19 cases. So first about communication. So we know how to do medicine, we know how to treat patients, and people ask me, why do we need a command and control and communication system for this pandemic? And I actually think that the challenge here brought a challenge that we didn't encounter in the past. First, in the COVID-19 pandemic, and we were afraid from that from the beginning, that there was a risk, and it actually happened in some cases for healthcare resource contingency, multiple patients, few caregivers, sometimes limited equipment. We needed to work with personal protective equipment. This actually limited our ability to effectively communicate with each other. So there was a communication challenge. And we also the pictures from Italy, from Spain. We had the risk for unpredictable, chaotic situation, and we all know that a solution for that may be harmonic teamwork for overcoming such a challenge. And as Dr. Halbert mentioned before, we needed to work in underground, extensive and secluded COVID-19 care domains in which communication is pivotal for success. So in Israel, we understood that this is very similar to a war, very similar to a battlefield. And in order to cope with that, we collaborated with Elbit Systems that developed the command and control system for our army. And we just used this similar system and adapted that to another battlefield, the battlefield for COVID-19, our medical battlefield. And you can see down here, our COVID-19 underground health hospital. This is the map, and these are the medical staff working in this COVID-19 underground hospital. We generated and established a new communication system and command and control system to manage this crisis in Rambam. What are the key features of these systems called X-Teams? It allows organized and hierarchical medical communications. It is based on group communication, so this allows to improve the staff efficacy. It is a role-based communication, so you communicate only with people that are active on duty. It allows location tracking, so you can bring the right medical personnel to the right place at the right time. It is COVID-19 proof. It allows a safe walk in the infected zone. It has tons of features, push to picture, push to video, but most importantly, it is intuitive. It is very easy to use. And a few days after we implemented it in the underground hospitals, we had more than 500 push-to-talk communications per hour. So all the communication within this underground COVID-19 hospital was based on this communication. The second pillar is the personal training. We all know that this is a challenge that we didn't encounter before. A new disease, a new pandemic, and we needed to train our staff. This was a time of infodemic, so we had a lot of data, but with mixed quality. We call it in Israel data faude, data chaos, and we prepared webinars for our staff. we used focused literature briefing using a novel Israeli artificial intelligence based systems, scanning all the preprints and the social media and bringing only the credible data out of it. We designed protocols. We need to train our non-ICU staff to become an ICU-like staff to get acknowledged with ICU procedures. And then a very important issue is that you need to train the staff as a team to communicate at the right setup in the underground hospital and to work as a team and to give them the tools to for a good teamwork. And then we got operational teams, organics teams that can work efficiently in the underground hospital. The third pillar, and this is, I think, the main issue of this session, is that we don't live as a hospital without a connection to the community. So connection to community is very, very important, but during COVID-19, it became crucial. So in order to prevent the surge of patients, you need to understand what is going on in your community, and we harness data science in order to help us identify early outbreaks. So we developed a data science-based system based on mathematical analysis to identify outbreaks. You can see the map here. The circle size is the number of cases, and you see the large number of cases in Jerusalem, in Tel Aviv, but the color is the disease spread rate. And this was August 14, the beginning of the second wave of COVID-19. And then we understood that unlike the first wave of COVID-19, this second wave is going to hit Northern Israel, not going to hit our hospital at Rambam. So you can see the red spots in Northern Israel. We also established a tool set for policymakers to couple the COVID-19 risk of a geographical unit with the appropriate mitigation and relief measures. We identified areas as hotspots of severe morbidity based on the age distribution and comorbidities. And we understood very early during the first wave that hospital burden is going to be a key issue. And we developed a hospital burden-based allocation system to efficiently allocate patients according to the hospital burden. So now every ambulance in Israel is directed to the right place the right hospital according to the hospital burden. Another important issue is a hotspot of severe morbidity is the nursing homes. And we in Israel have a special program for that, the Shield of Fathers and Mothers. And we created a data science-based tools for this program for surveillance of outbreaks in these nursing homes to early identify these outbreaks and to mitigate them effectively. And finally, we all experience pandemic apathy or exhaustion, and also the community. It's very, very important to understand that. And we've developed tools for identifying, so these are actually novel epidemiological indices for identifying hidden COVID-19 morbidity and to focus on these areas and to focus the epidemiological efforts on these areas. And we can use this same system not only for Israel, but also for the US. You can see here that the outbreak currently, this is from yesterday, and in the US is in the Midwest, in the Southwest. Actually, when looking at Stanford area, it looks very calm, so that's good news. And just to summarize, I think that we need to get prepared. Thanks God, we didn't have a real healthcare contingency, even in the second wave in Israel, and I hope that we will not have it, and we will stay with this proportion of healthcare providers to patients, as you see here. But seriously, the main issue with this pandemic is teamwork, multidisciplinary teamwork, working together, healthcare providers, engineers, data scientists, trying to overcome the challenges of the unknown. And I think in Rambam, we had a very good experience in using teamwork in order to cope with this challenge. Actually, one of the secrets that a few months before the COVID-19, we had a minor crisis. A major plumbing pipe broke down in the top floor in Rambam. And you can see here a miniature drill for teamwork. Everyone is doing everything. Everyone is participating in the effort. So I would like to thank all the people in our research team, in Rambam team, and the companies that we collaborated with in Elbit and the Ministry of Health for participating in those efforts. And I will be very happy to take questions and discuss. Thank you.
Thank you, Dr. Caspi. I'm curious to hear from our different hospital representatives how your hospital coordinated with the other healthcare systems in your area in responding to COVID.
So I'd be happy to discuss that. So we had a chance to connect not only individually with different hospitals to hear what their experiences and what their preparations were, but we also had to be able to connect through different organizational and governmental abilities. So that way we could have a coordinated response within the county. And so that actually worked quite well when we were planning out surge plans for if there was a massive surge, where we could allocate patients, where we could allocate different pharmaceuticals. And that open discussion that actually happened, which has not happened in other past experiences, was actually extremely helpful in order to plan different contingency plans.
For us here in Santa Clara County, we have a couple different touch points. One of them is we do a daily poll of bed capacity, and it's also the number of suspected and confirmed patients that we have, as well as any related deaths. And that goes into our EMS dashboard every single day by noon. And so that's one opportunity that we can share our data with the county to give them some situational awareness, but also we can see all the other hospitals in the county's responses, and they can see ours. And then in addition to that, like we talked about earlier with the resource request process, we report in through the medical health branch director of our operations section of the county emergency operations center. And they've been a really key part in not only the resource request, but also something that was kind of unique that came up during COVID-19 was they appointed a physician to be our kind of unofficial liaison with the emergency operations center. And so it was really helpful to have that physician perspective and be able to connect and just kind of identify if there are any potential roadblocks in the county process that they could help us more personally with. But I think another thing, just back to community relationships, that's been so critical in our success here is that offline, what we continue to do, and have been doing for many years, is that the California Hospital Council also helps facilitate a group in our county called the Santa Clara County Emergency Preparedness Partnership for Hospitals. And it's the emergency managers from each of the hospitals within our county. And we meet at least once a week or once a month, sometimes weekly during COVID. And that was really a great opportunity to have some qualitative exchange, to just kind of have some more candid discussion about, okay, what do you think about this health order? How are you going to meet this? What are you thinking of doing for your visitor restrictions? What policies are you going to have? And so it was a nice, more informal way to just be able to discuss and have some consistency, because we know that our patients and our families and our staff are potentially visiting different parts of the health system within the county. And so having some consistency and also just some alignment and support was really important.
So Dr. Caspi, do you have anything to add about systems coordination? It sounds like you guys have a very thorough system in place over there.
Yeah, I think that regarding system coordination, a key issue is going out to the community. And, during the COVID-19 pandemic, especially in the Arab community, and I think that Dr. Hussein will talk about it later on, giving them the guidance of how to prevent COVID-19 spread was a key issue, and currently a key issue in order to prevent the surge of patients. And working together with the community hospitals, working together with the community clinics in order to identify COVID-19 in those areas that we thought there is hidden morbidity and even hidden COVID-19 outbreaks was crucial in order to cope with this challenge.
I'd also be curious to hear if there are any strategies either considered or deployed given the amount of misinformation out there and having to work with communities, given that there was resistance to some of the public health measures and again, sort of inconsistency about what it is that we can do to safely combat and prevent the spread of COVID.
I think that transparency is a key issue. I think it was raised before. So one of the advantages of our maps that are available to the public is that transparency regarding the outbreak kinetics is known to everyone. Everyone knows that if it goes from one area to another area, what is the risk at that area, and he can calibrate his protective measures accordingly. So I think this is a key issue: transparency, being very transparent with the community, allowing them to understand the disease is a key issue to win that.
Yeah, I think I could just add to that initially when we were tracking this back in mid-January, early February, at first there was a lot of secrecy about it. There was a lot of uncertainty about what the scope of it was, what was going to be the impact. And so it's interesting to reflect on what our processes were for those initial patients who were suspected of COVID-19 to how far we've come. And I agree with Dr. Caspi. I think transparency is sometimes a difficult thing to tread through because you are trying to protect the security and the privacy of your patients as well. But we'll people and be pretty open and transparent what the scope is within your facility. And I think that's been a key part to the success in the state of California, but particularly in the Bay Area, has been how our county and our region has leveraged that data to make it publicly available. And not just the number of cases, but also pretty transparent about what the testing capacity is and to help people understand the challenges that the health system is facing and what we're doing to improve it, but understand that there are challenges that we're still working through.
I'm in total agreement, and it's been very good to have that transparency in terms of the lab data. So the lab data is available by county, and you can see the number of tests that were performed, the positivity rate has been publicly released, and that's been very helpful in communicating with patients to let them know the importance of different protective measures.
Now, similarly, kind of dealing with community messaging, if we sort of flip that around and we talk about what were some of the challenges that you encountered, specifically dealing with messaging and coordination and communications within your own systems. I realize healthcare workers had to adapt, evolve very quickly to a new normal. So what were some of the strategies employed there?
So one of the challenges that we had was the difference in size of the hospitals. So community hospitals are different size and have different resources than academic tertiary care hospitals. Stanford has been fantastic in creating a meeting called COURT, which is the Clinical Oversight Resource Team, which is an opportunity for all parts of the organization to come together and to discuss different measures to protect healthcare workers and staff and the patients. And this is a great resource team to have, basically to talk about the challenges of implementing different initiatives at different locations. It's very open, it's very transparent, and that's been extremely helpful, just simply because, again, different parts of the organization have different resources, different personnel, different structures in place. So that was a very helpful structure.
Dr. Caspi, any thoughts about internal messaging with Rambam?
I think that regarding internal messaging, in the initial days, weeks of the pandemic, there was a lot of anxiety in the people you work with, for yourself, for other healthcare providers, for our patients. And I think that knowledge was crucial in order to cope with that. So I mentioned the webinars and the literature briefing and taking off all this infodemics data, the mixed quality data, and bringing mainly the high quality data to the table was very important in order to help people understand the disease, be confident in the PPE they are using, be confident in the treatments they are giving, lower level of uncertainty help in coping with anxiety. So this was very important for internal messaging and coping with the disease.
So I do feel like one of the fastest ways to erode some of that faith is to have the messaging constantly changing. So I will say, just from personal experience, one of the things that I really appreciated about Stanford was, as was mentioned earlier, some of that humility, and as we discussed here, that transparency. I think that really helps. So I'm noticing that coming out as a theme for the success of all of our respective systems. So one thing that's coming out of our chat is, how do the pre-hospital personnel receive follow-ups on patients they've transported? So not only maybe in the patient condition, but potentially how do you deal with some of the exposure issues as well with that interface between our EMS and our hospital systems?
I guess I can kick us off. There's very detailed contact tracing processes that the county has put in place. And so that's where having those existing relationships and systems for reporting the infections within our hospital also helps with the contact tracing in the county. I think also just having those ongoing partnerships, and Dr. Masters, you could probably also speak to this, of just between the emergency department, where a lot of these patients are coming through, and the EMS systems that are typically bringing the patients in. There's also an opportunity there for the dialogue and partnership directly with those agencies, whether it's the county EMS system or maybe one of the fire departments. I think those relationships that are built over time are also really important.
So I'll take a quick moment again to remind our audience that in the right-hand side of your screen, the upper right-hand side, you'll see the chat bubble. So if you can get any questions, then we'll have, I think, just enough time for one or two more. But Dr. Caspi, what methods did you guys have over there at Rambam for contact tracing?
So first of all, we had an epidemiological team that did contact tracing and epidemiological investigation for any case in the hospital, any case of a visitor, any case of a patient, any case of a healthcare provider. And regarding the EMS, I think it's very similar. We are familiar with our EMS in routine, so we have a very intimate relationship with them, and any case that was relevant was notified in a very, very short short time. So that was, this wasn't a key challenge in this event.
So this one might be for Dr. Svec and Dr. Caspi. It just came through the chat function that airlines have faced difficulties with people refusing to wear masks. How have hospitals handled patients or visitors claiming medical conditions or simply refusing to wear masks? It might be a little different for our visitors versus our patients, given what we can allow.
So I think in our place, we limited the number of visitors. So this actually helped in coping with this problem. It was very rare that a visitor refused to wear a mask, and most of the time, just a detailed explanation was enough to encourage him to wear a mask. I think that, once you are explaining, you ask why, what was the problem, you ask for his reason for not wearing or not going with your recommended measures. Most of the time, this helps in solving the problem. So we didn't have a huge problem like the airlines with that.
We similarly, luckily, did not have a substantial problem with this. We did train our security. Our infection control team would sometimes respond if there were any questions, and also our nursing staff was always present. But luckily, at this to this point, we have not had any substantial issues with it.
So it seems we kind of come back to that theme of just very coordinated, very consistent messaging. I think that's really one of the things that has led all of our hospital systems to be fairly successful on the front edge of this. Any questions within the group for each other, or any additional thoughts as we wrap this up?
I wonder on one thing. I think that during March or April, hospitals were interpreted in the community as hazardous points, as areas that COVID-19 is COVID-19 infection is a risk there. And what happened, at least in Israel and specifically in Rambam, is that now patients understand that actually the hospital is a very, very safe place. So, because everyone is taking the right measures to prevent COVID-19 spread, and we almost don't see patients that, come, I'm doing a heart failure clinic. We almost don't see patients that don't want to come for ordinary treatment in the hospital. So I wonder how it is in Stanford, how it was in the beginning, and was it the same?
I think I can jump in and just say that was one of the challenges we had, is the number of people who feared the hospital setting, when in fact some of the measures that we had in place made us one of the safest places to be. Well, thank you guys so much for joining us. I really appreciate the perspectives of all of our different institutions.